The Max Foundation has joined with patient groups across the world to proclaim September 22nd as International CML Awareness Day in an effort to help raise awareness. I am here today with Dr. Jerry Radich of the Fred Hutch, and he's going to help us with a quick update on CML. So, Dr. Radich, can you begin by giving us an overview of CML and who it affects?
Sure. CML is a disease of the hematopoietic system, the blood-forming system. How normal blood is formed is that there are unique cells called stem cells, and those stem cells differentiate into your platelets, which basically help you clot, the red blood cells, which carry oxygen, and the white blood cells, which are used to fight infection. In CML, every patient with CML has a unique genetic abnormality, the Philadelphia chromosome, which is a chromosome discovered in Philadelphia in the early 60s. And what it is it's a translocation, which means a piece of chromosome 9 is hooked onto a piece of chromosome 2, forming a completely new genetic element in the stem cell. What that does is it causes a proliferation of your white blood cells. So whereas my white blood cells are probably running somewhere between 5,000 to 10,000, the normal patient with CML will have a great expansion of their white blood cells to 100,000, 200,000. That usually occurs fairly innocently and without much clinical problems. And so most people with CML are diagnosed on a routine physical for insurance and the like, and are found to have the high white blood cell count. It can cause symptoms if it goes higher and higher. Most patients are diagnosed in the so-called chronic phase, which is just an expansion of the white blood cells. As time goes on, if you are not treated with some type of curative intent, it will progress to an advanced phase, accelerated phase, and then a blast crisis, which can be fatal because of bleeding complications and infection complications as the disease takes over all the normal blood-forming elements. It's a relatively rare disease. It happens somewhere between 1 to 2 cases per 100,000 patients or people. It's rare in pediatric cases, and it increases in incidence as age increases.
Okay, so that helps us to understand a little bit about how September 22nd was chosen, 9/22 as the date.
Right.
Can you also give us a little bit of a historical overview of CML over the last 15 years?
Right, so in ancient history, when I started doing this about 25 years ago, there were really very few therapeutic options. The only way to cure anyone, really up to the last decade, was by bone marrow transplantation, which is highly efficacious, but a potentially toxic therapy. The problem is, of course, is that most people don't have donors. With the expansion of unrelated donor pools, more patients are available to have donors. But still, transplantation is really an option for people who are younger, usually less than 65, and the median age of CML onset in many countries is over 65. So the transplantation, while being quite effective, really can only benefit really a very small population of the total CML patients. And so in the old days, if you didn't have that, the only other therapy that had any change in the natural history at all was interferon, which is quite toxic and really isn't that effective. I mean, it can cause a complete cytogenetic remission in maybe 10% of patients, maybe 15%. So it's really not very optimal therapy. And so obviously all of this changed with the advent of tyrosine kinase inhibitor therapies, which has made a remarkable change in the natural history of the disease. If you looked at 1 to 2 year survivals 20 years ago or so, that would probably be about 75%, and eventually 5 year survivals would be 50% or less. Now 1 year survival with people on tyrosine kinases are 95% and greater, and most people are expected to, if they're treated in chronic phase, are expected to live a long life and not have any major complications.
And so, what do you think are the questions that are yet to be answered in CML?
Well, I think that there are 3 questions that I sort of hone in on. One is, the first tyrosine kinase that was approved for therapy was imatinib, Gleevec, which is quite effective. There are now, however, 2 so-called second-generation drugs that have been approved in the United States, dasatinib and nilotinib, which, at least in short-term studies, are probably actually more effective. The question is going to be, though, is that as Gleevec becomes off patent, it's going to become generic and very cheap. And one of the major issues is how do you integrate therapy with a cheaper drug with that which is a much more expensive drug but maybe more efficacious. And you treat patients with Gleevec and only treat those people who don't respond with the higher, more potent, more costly drug. Do you start people on the more potent drug, and if they get a good response, switch them over to a cheap drug, which will take forever? I think that's going to be a very, very interesting question to resolve. Can we use molecular methods, kind of high-powered molecular assays, to determine which patients would be better to be on imatinib versus one of the second-generation drugs? So that's, I think, one big issue. The second issue is that some people still, despite all these therapies, there's still a proportion of patients who either won't respond right off the bat or will relapse and become resistant to one of these therapies, or will progress to accelerated phase blast crisis. And so the challenge there is to figure out which patients are going to do this by using more sensitive tests to monitor the patients and maybe monitor for resistance early on so you can catch it early. And then the second question is, if you catch it early, how are you going to treat it? And I think there we have to talk about the potential for combination therapies, tyrosine kinases plus some other types of therapies that will change in natural history. The third thing I think is the really fascinating data now that some patients can get off these therapies after some time. When we first started treating patients, we thought that you have to be on tyrosine kinases forever. It looks now that they're in patients who become negative by a PCR assay, which is a very sensitive assay. If you are negative for several years, about 40% of patients can get off drug and stay off drug. Now, those people haven't been followed for a long period of time. We don't know if they're really completely out of the woods or not. But it is quite actually hopeful that, in fact, if you got people into a so-called molecular negativity, that you could actually get people off drugs. And to do that, we'll probably need to combine these agents with some other agent. So I think that one of the big pushes is going to be adding on to the efficacy of these tyrosine kinases with yet another agent, a some kind of combination, to see whether or not you can actually make people purge them of the disease altogether and allow them to then get off therapy. And obviously you have to carefully monitor those people and put them back on therapy if you needed to. But I think that's really going to be really quite an avenue for clinical research in the next years.
Well, it seems like it's a very exciting time ahead, and actually the story of CML is a really good one to help raise awareness about, because it has implications for how it can help with other kinds of cancers as well.
Yeah, we think we've always put out CML as really the model of where cancer therapy should be, so we could find a unique marker of the disease, a unique genetic defect that drives the pathogenesis, use that as a target for both therapy and for monitoring, and really redirect the whole natural history based on actual molecular knowledge. And it's always been really the poster child of the old bench to bedside approach, and we hope that that will be actually translatable to other diseases as well.
Yeah. Well, we thank you very much for the research you're doing every day and for helping to improve outcomes.
Great.
Thank you.
Thanks.